All right, so we're diving deep today into the world of perinatal coding, specifically Chapter 16 of the ICD-10-CM, which, let's be honest, can be a little tricky.
Yeah,
It covers like the first few days,
Yeah.
weeks, even months of a newborn's life.
Mhm.
And getting those codes right, it's a big deal.
Huge, not just for healthcare folks, but anyone who,
Wow.
wants to understand the long-term health picture for these little ones.
Exactly. And to help us out, we've actually linked the Absolute Medical Coding Institute's Medical Coding Guidelines Manual, MCG, down in the description.
So you can follow along.
Yeah, check it out. All right, let's get started.
Let's do it. Chapter 16. Certain conditions originating in the perinatal period. Codes P000 through P96. That's where it all begins. A newborn's health journey.
Okay, so right off the bat, big thing to remember. Those codes, they're only for the newborn's record, never the mother's.
Right. Super important to keep them separate for accurate data, tracking, maternal and newborn health outcomes. But keep it all straight.
Makes sense. Now, how about coding the birth itself? Where do we even begin?
The grand entrance. That's where those Z38 codes come in. Think of them as like the opening scene,
Okay.
Place of birth, type of delivery. Use just the once, right at the moment of birth.
So just to be clear, if a newborn, let's say they're transferred to a different hospital, that receiving hospital, they wouldn't use a Z38, right?
Nope. That original Z38 code, it stays put right on the birth record, the first one.
Okay, got it. So Z38, that's like the foundation. But then what about those situations where there's more to this story? Like a newborn has something going on that needs a code, but Chapter 16 just doesn't have it. What then?
Oh, it gets interesting. We actually can pull codes from other chapters to give us more detail. For example, let's say a newborn, right? They have these symptoms, but the diagnosis isn't quite clear yet. We can use codes for those specific signs and symptoms along with the Chapter 16 code to give us the full picture, like a puzzle.
It's like layers, right, to a painting.
Exactly. And that's where the principal diagnosis comes in. If the reason for the encounter, whatever it is, evaluation, treatment, even just observation, if it's related to the perinatal period, that Chapter 16 code takes center stage, the primary code.
This has always made me wonder, what if a condition from those early days, sticks around? Do we keep using the Chapter 16 code as the child gets older, even as an adult?
Absolutely, we do. If it originated in the perinatal period and it's still affecting them, that Chapter 16 code stays with them no matter their age. It shows just how big of an impact those early days can have.
Wow. That's pretty powerful. Okay, so what about those cases where it's not clear if a condition was present at birth or developed later? How do you decide which code to use?
Unless the provider clearly says in their notes that it was acquired after birth, we default to assuming it originated during the birth process and use a Chapter 16 code. Got to capture the most accurate info we can based on what we know.
So you lean towards the perinatal period unless you have clear evidence to say otherwise. Got it.
Right. Now, with all these conditions, how do we even know what's important enough to code? It can be overwhelming.
I was just thinking that. What's the guideline for deciding what makes the cut? What do you look for?
Clinically significant conditions.
Okay, give me the rundown. What does that actually mean?
So these are conditions, right?
Yeah.
Noted on a routine exam, the newborn exam, they got to meet a certain criteria. Like, did it need a clinical evaluation, treatment, specific procedures?
Makes sense.
Did it make the hospital stay longer? Or did the baby need more monitoring? Anything that takes extra care or resources.
Got it.
And one more thing. We also code conditions that the provider specifically says have implications for future health care. This is particularly important for newborns because it's all about setting up their health record from the start.
Oh, I see. So it's like building a roadmap for their future health right from the beginning.
Exactly. And this guideline, it's only for newborns, okay? We wouldn't apply it to adults. They already have a medical history. For newborns, we're building that foundation.
Okay, that makes sense. What about those times, though, when there's suspicion of something, but then it turns out to be a false alarm? How do you handle that when coding?
Z05 codes. Those are specifically for observing and evaluating newborns for suspected conditions, that end up being ruled out.
So if a healthy baby gets checked for something, but it's all clear, we use a Z05 code. But what if the baby actually does have symptoms?
If there are symptoms, we wouldn't use Z05. We'd code for those specific symptoms.
Okay, so Z05 is strictly for healthy newborns, being observed just in case.
Right. Now, those Z05 codes, they can be used in a couple of ways. They can be the primary code for readmissions, encounters, after the initial birth record, since that initial Z38 code isn't relevant anymore.
Right, because after that first record, it's all about specific conditions or observations.
Exactly. But remember, only for healthy newborns. No confirmed condition after a thorough evaluation.
No sneaking those in for babies with actual issues. So on the initial birth record itself, where would a Z05 code go? If it's used, I mean.
Secondary code, listed right after that Z38 code.
Okay, so Z38 always leads the way on that birth record. I'm starting to get the hang of this. But what about those extra diagnoses? Beyond those initial observations, what's the rule there?
Good question. Basically, any condition that needs treatment, further investigation, something that prolongs the baby's stay in the hospital, or just consumes those healthcare resources.
Anything that has a big impact, right?
Yeah.
On their care during their stay.
You got it. And another thing, conditions that the provider notes as having implications for the future healthcare needs,
It's like creating this whole tapestry
Yep.
of the baby's health journey, right from the start, looking ahead to what might come.
That's a great way to put it. And this guideline, again, just for newborns, we wouldn't do this for adults. Their history is already there. For newborns, it's all about setting up their health record right.
Okay, that makes sense. So we've covered a lot about general conditions, but what about prematurity and fetal growth retardation? I feel like those are more, unique situations.
Absolutely. Those have their own set of coding rules, and we'll dive into those right after a quick break. Back to those guidelines. Prematurity, fetal growth retardation. First things first. You got to understand, providers, they use different criteria to decide what's premature, right? So we never, ever assign a code for prematurity unless it's specifically documented by the provider in the baby's record. We trust their judgment on that.
So it's all about the documentation, no jumping to conclusions.
Exactly. Now, coding for birth weight and gestational age, that's where categories P05 and P07 come into play, based on, the recorded weight and the gestational age at birth.
Okay, so we're talking hard numbers here, objective measurements.
Yep. And here's something interesting. If both the weight and the age are documented, we actually use two P07 codes. The birth weight code comes first, then the gestational age code.
Oh, so there's an order, even within those P07 codes. Interesting. It makes me think about like the long-term picture. Babies born premature or with low weight. Does that affect their coding later in life?
It can, yeah. Those P07 codes, we usually think of them for newborns, right? But they can actually be used for anyone, kids, adults, doesn't matter. As long as their premature birth or that low birth weight is still affecting their health.
Wow, that's pretty amazing. It really shows you how much those early experiences can shape a person's health. So birth weight, gestational age, conditions at birth, potential long-term impacts. But what about those unexpected things? Like, let's say a newborn develops bacterial sepsis. How do you code for that?
That's a good one. So bacterial sepsis in newborns, that's category P36, congenital sepsis. And here's where it gets a little tricky.
Okay.
If the specific bacteria causing the sepsis, right, if that's already part of the P36 code description, we don't need to add another code from categories B95 or B96. But if the P36 code we chose doesn't specify the bacteria, then we'd add a code from B96 to give us that extra detail.
So it depends on how specific that P36 code is. Not too much info, not too little, just right. What if, the sepsis is severe or starts affecting other organs?
Then we would add codes for severe sepsis. That's category R65.2-, and any codes for that acute organ dysfunction.
Got to capture the whole picture,
Yeah.
all the details.
It's like a puzzle. Got to make all the pieces fit.
Yeah.
So we've covered a lot of different situations, but there's one that's, it's a sensitive topic, stillbirths. How do you approach coding for those?
Yeah. So for stillbirths, we use code P95. But there are some very specific guidelines for using this code.
Okay.
P95, only used in places that keep separate records for stillbirths. To keep things clear, between the baby's record and the mother's.
So it's acknowledging that this is a separate, sensitive event. It needs its own documentation.
Right. And we never, ever use P95 on the mother's record. It's only for the stillbirth itself.
Makes sense. Now, before we wrap up this perinatal coding deep dive, one more thing I got to ask. COVID-19, it's a big one these days. How do you code for that in newborns?
That's a very timely question.
Yeah.
So newborns with a positive COVID test, we use code U07.1. That's the specific code for COVID.
And just like with other conditions, we'd also add any codes that describe their symptoms, right? The specific things they're experiencing.
Layering those details. Again.
Exactly. And if the provider's notes say that the infection happened, like in utero, or during the birth itself. We'd add another code, P35.8, which means basically other congenital viral diseases.
So you're specifying that it wasn't acquired after birth.
Right. We're pinpointing the origin. And even with COVID, we always use that Z38 code as the main diagnosis on the birth record.
Right. That Z38 is like the anchor, the foundation of the whole thing. It's amazing how much these codes, they seem like small things, but they really do tell a story. And it's a story that can have a big impact on a person's health and on how we understand health trends. But I feel like there's got to be even more to this, more to uncover.
Oh, absolutely. There's always more to learn. But before we go any further, let's just take a moment, reflect on what we've covered.
This deep dive, it's been, wow, really eye-opening. I never realized perinatal coding was so complex. So many details.
Yeah, it's pretty intricate.
It's like this whole secret language, unlocking all this information about, healthcare.
Yeah.
Those first moments of life. It's fascinating.
It is. It really is. Those codes, people see just numbers and letters, but they tell a whole story, a person's health journey. And it can even affect them, their whole life. It's amazing how these little details, they can shape so much. Healthcare, research, even how we understand health trends.
Absolutely. It's like each code is a thread and you weave them together. You get this whole tapestry, a complete story. So as we wrap this up, what are some of the big takeaways, the things our listeners should really remember?
Okay, so Chapter 16 of the ICD-10-CM, that's our Bible, our guide for perinatal coding. It helps us navigate all those different scenarios and make sure we're accurate.
Right, and those Chapter 16 codes, newborns only. Never for the mother.
Right. Got to keep those records separate.
Yeah, super important for accurate data. And then, of course, we always start with that Z38 code on the initial birth record.
Yeah, that Z38. It's like the starting point, place of birth, type of delivery.
Yeah.
Sets the scene.
Exactly. And from there, we add more codes, right, to capture any conditions, observations, procedures, pulling from other chapters if we need to. We could even use codes for, like, signs and symptoms if we don't have a clear diagnosis yet, just to make sure we get that full picture of the baby's health.
Fill in all the gaps.
One thing that really stuck with me is how those Chapter 16 codes, you can use them throughout a person's life. If that condition sticks around, that's pretty powerful,
It is. It really shows you those early days. They can have a long-lasting impact. And remember, if we're not sure where a condition came from, we assume it's from the perinatal period, unless there's documentation that says otherwise. We want to capture that potential impact.
Oh, and those clinically significant conditions, that was a big one for me. Yeah. We code anything that needs extra attention, impacts the baby's care, or could affect their health in the future.
Yeah, those criteria help us focus on what matters, what needs to be documented, and then we have those Z05 codes for those healthy newborns who are being watched, just in case.
Right, and if there are actual symptoms, we code for the symptoms, not just the observation.
Exactly, we need that level of detail. And those Z05 codes, sometimes they're even used as the main code for readmissions, encounters, after the initial birth record. So that observation period, it can really affect later care.
I'll admit I was a little nervous about prematurity and fetal growth retardation coding at first, but you explained it so well.
Those can be tough, yeah. But as long as we understand the guidelines, we can be accurate. For prematurity, we always look to the provider's documentation. We trust their judgment. And for birth weight and gestational age, we use those P05 and P07 codes. Always remembering birth weight code comes first. It's all about that order.
It's like a coding dance, right?
Yeah.
Got to get the steps right. And it's amazing, those P07 codes. We think of them for newborns, but anyone can have them. If they're premature birth or low birth weight, it's still affecting them. Doesn't matter how old they are.
Exactly. It shows that a person's health, it's a journey, it's ongoing. We also talked about bacterial sepsis, adding that B96 code if the specific bacteria isn't in the P36 code. And we always include codes for severe sepsis or organ problems if those are happening. We got to capture the whole situation, the whole picture.
And stillbirths. Coded P95. Only for institutions that keep those records separate and never on the mother's record.
Right. We got to be accurate, but also sensitive. And then we talked about COVID-19, using U07.1 for newborns who test positive, plus any codes for their symptoms, and P35.8 if the infection happened before birth.
It's really incredible how these codes can help us understand something like COVID, its impact on those little ones. This deep dive has been, wow, really insightful. I feel like I have a whole new understanding of perinatal coding. It's so much more than just data entry.
I'm glad to hear that. It's about telling a story, shaping healthcare, improving lives.
Well said. Now, before we go, Something to think about. As we learn more and more about the long-term effects of things that happen in the perinatal period, how will coding need to change to capture those nuances and make sure people get the best care possible throughout their lives? It's a big question. And if you want to learn more, check out that MCD manual. It's linked below. Accurate coding, it's so important to make sure every health story is told the right way.
Until next time, keep those brains working.